Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled Addressing Healthcare Disparities with Postpartum Hypertension Care Through Clinical Pharmacist Integration. We are thrilled to have Dr. Jim Thurston as our guest, who will be presenting. Jim Thurston is an ambulatory care clinical pharmacy manager at NewYork-Presbyterian Hospital, where he independently sees patients for disease state management under CDTM agreements in an internal medicine clinic and postpartum hypertension clinic. He completed his PGY1 in acute care at Prisma Health Upstate in South Carolina and completed a PGY2 in ambulatory care at NewYork-Presbyterian. His current practice interests include primary care, cardiology, remote patient monitoring, technology. Outside of pharmacy, Jim enjoys traveling, board games, and watching the Brooklyn Nets. Before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. The CE code will be provided at the end of the program. And with that, I would like to welcome Dr. Jim Thurston to be our presenter.
Great. Thank you, Dr. Caliendo, for that introduction, and thank you all and NYSCHP for having me here presenting today. As Dr. Caliendo mentioned, my name is Jim Thurston. I'm a clinical pharmacy ambulatory care manager at New York Presbyterian, where I'm embedded in a number of clinics, one of which is a postpartum hypertension clinic at a Weill Cornell campus that's relatively new. And today's presentation is really focused on highlighting the risks within the postpartum period, specifically related to hypertension and the complications from it causing more maternal morbidity and mortality. But more specifically, diving into the healthcare disparities within postpartum care, how this affects Black women and women of color at disproportionate rates, and how we, as clinical pharmacists and clinical pharmacy technicians, can assist with addressing these barriers and hopefully lowering the risk of maternal morbidity and mortality for these patients. Okay. And to start, I have no financial disclosures or conflicts of interest. And for pharmacists attending today's presentation, I'd like you to be able to, by the end of this presentation, describe healthcare disparities within postpartum care and understand how they directly impact health outcomes and the risk of maternal morbidity and mortality. Recall the common barriers that patients face to care within the postpartum period. Discuss how we as healthcare providers can close healthcare gaps through interprofessional collaboration with multidisciplinary team members and also through utilization of telehealth. And then finally, understand how we, as pharmacists, can personally impact and address these barriers within postpartum care. And similarly, for pharmacy technicians, be able to describe these healthcare disparities within postpartum care, recall the common barriers that patients face, discuss how we could close these healthcare gaps, and then specifically understand how you, as a pharmacy technician, can help address these gaps. So to start off in the background, I'll start off with a polling question, which is true or false, maternal morbidity in the United States has been decreasing over the past 3 decades. And I'll give you a few seconds to answer. So 74% said false and 26% true. Unfortunately, for this answer, the question is false. And if we look at the data, we could see that maternal morbidity has actually doubled within the past 3 decades in the United States, which is actually in stark contrast to pretty much every other developed nation, which has seen maternal morbidity and mortality actually decrease during the same time frame. We also know that 40% of all maternal deaths occur during the first 6 weeks postpartum. So I think this is in contrast to how many people think about the risks of pregnancy, mostly occurring immediately prior to delivery or during delivery. But I think that leads to a lot of healthcare practitioners and people overlooking the risks that happen within the postpartum period and the risk of mortality and morbidity specifically. We know that cardiovascular causes account for nearly half of all maternal deaths. So when talking about cardiovascular causes, we're talking about stroke, heart attack, eclampsia, other things related to hypertensive disorders. And then finally, we know that 60% of pregnancy-related deaths are preventable. So this is a good thing that we know that these are preventable, but also highlights the work we have to do within the healthcare space to actually prevent this morbidity and mortality from happening in the first place. When we talk about cardiovascular causes, a lot are related back to hypertensive disorders of pregnancy, or HDP. These complicate around 15% of pregnancies, are, as mentioned, a significant driver of maternal morbidity and mortality, a leading cause of postpartum readmissions, and we know that these diseases during the pregnancy period actually increase the risk for long-term cardiovascular disease. So if you're diagnosed with one of these things during pregnancy, such as gestational hypertension or preeclampsia, you're actually at a greater risk of chronic hypertension and other cardiovascular diseases later in life. So it's an important thing to acknowledge during pregnancy that this is increasing the risk in the long term as well, not just the short term. Within this umbrella of hypertensive disorders of pregnancy, we have a few different subgroupings. So we have chronic hypertension, which is your classic hypertension that can be diagnosed for any patient outside of pregnancy, blood pressure greater than 130 over 80 on multiple different readings, and is specifically diagnosed prior to 20 weeks into gestation. And how this differs from gestational hypertension is diagnosed at least after those 20 weeks of gestation. So it's diagnosed during the pregnancy period, and it actually has a higher blood pressure threshold. So when we're talking about diagnosis of gestational hypertension, instead of that 130 over 80, we're looking at two or more readings above 140 over 90, or at least one reading above 160 over 110. Next is preeclampsia, which is essentially a more severe form of gestational hypertension, in which the hypertension is actually starting to affect end organs and causing end organ damage due to that hypertension. So preeclampsia is diagnosed when a patient meets the criteria for gestational hypertension, but also has protein leakage in the urine showing kidney damage. And it could be labeled as with or without severe features based on damage to other organ systems. So such as elevated liver function tests, thrombocytopenia, pulmonary edema, severe headache showing neurologic damage. And preeclampsia can be on top of chronic hypertension as well. So in that case, we would call it superimposed preeclampsia. But all of this to say, with chronic hypertension, gestational hypertension, or preeclampsia, they all cause their own risks during pregnancy. And the eventual end step, if these things aren't caught and resolved, is potentially the risk for eclampsia. And eclampsia is essentially severe neurologic complications due to elevated blood pressure in the brain caused by hypertensive encephalopathy, which could cause seizures, coma, and eventually death. When we think of the pathophysiology for hypertensive disorders of pregnancy, it's a little complex and not fully elucidated, but what we think is happening to cause this is risk factors within the mother that are causing abnormal trophoblast development, trophoblasts being the parts of our original blastocyte or egg that are forming the placenta during the pregnancy period. And these trophoblasts are abnormally forming the actual blood vessel supply and vasculature to the placenta that's bringing the fetus blood and therefore oxygen. When the blood vessels aren't formed correctly or as efficiently as they should be, it's not bringing an efficient supply of oxygen to the baby. And because of that, the baby and mom start to release essentially pro-inflammatory factors and anti-angiogenic factors. So essentially preventing new blood vessels from forming and then increasing inflammation, decreasing vasodilation, and therefore increasing vasoconstriction systemically for the mother throughout the body, which is leading to that end organ damage outside of just placental perfusion. So for question 2, we'll talk a little bit more about risk factors in this background section. So which of the following is considered a key risk factor for maternal cardiovascular mortality? Would you say age less than 40 years, Black race, greater than 3 previous pregnancies, or a vegetarian diet. Okay, so the answer here is primarily Black race with 78%, which is the correct answer. With age greater less than 40 years, we'll see that actually the risk factor is for age greater than 40 years. So we have Black race, age greater than 40 years, prior history of hypertensive disorders. So, for example, if a patient has chronic hypertension, there's a greater risk of them developing gestational hypertension or superimposed preeclampsia during pregnancy and it leading to those cardiovascular complications. And then finally, obesity, which could lead to a variety of cardiovascular conditions. Diet and number of pregnancies isn't as correlated with cardiovascular mortality. In terms of hypertensive disorders of pregnancy management, our general approach to management should rely on clinical surveillance and early diagnosis. So um, for many patients, it's important that we are catching these hypertensive disorders as early as possible so that we can manage them and prevent the complications from actually occurring. We manage these complications through blood pressure control and sometimes medication management if it's needed. So it's important throughout these steps that a patient has early follow-up with their obstetric provider, that they are followed by a primary care provider prior to diagnosis if possible, or prior to pregnancy if possible, to have these things diagnosed prior to pregnancy, because we know they're going to be higher risk during pregnancy. And luckily, we do have guidelines that um, have some guidance on treating patients in the postpartum period and optimizing care in the postpartum period. I will say that the majority of guidance and evidence that's been released historically has actually been in the antepartum or peripartum period, not so much the postpartum, but more and more guidance is starting to come out about the postpartum period because we're finding out that the risks of mortality and morbidity extend into this period. So in this 2018 committee opinion article from the American College of Obstetricians and Gynecologists, they offer some guidance on how we can actually optimize care in the postpartum period. And they say that blood pressure evaluation is recommended for women with hypertensive disorders of pregnancy no later than 7 to 10 days postpartum. So around the first week postpartum. And women with severe hypertension, so think preeclampsia with or without severe features, should be seen within 72 hours. And the reason for this guidance is that further data has showed that greater than 50% of postpartum strokes occur within the first 10 days of discharge. So if you think about that, for one of those first slides that showed the risk within the postpartum period within those first 6 weeks, 40% of the maternal deaths happen during those first 6 weeks postpartum. But even more so, a patient is at higher risk within the first 10 days postpartum in terms of hypertensive disorder pregnancy management. It's the highest risk for these risks within the postpartum period. And as you can imagine, it can be extremely difficult for a patient who maybe has just delivered, maybe had a difficult pregnancy, has a newborn at home, maybe has other children at home, maybe doesn't have other caregivers at home, to ask them to come in for an in-person visit within 70, maybe 72 hours of discharge. It's almost like an impossible task for these women with a lot going on at home after hospitalization. So at least this opinion article or this committee opinion acknowledges this and says the usefulness of in-person assessments should be weighed against the burden of traveling to and attending an office visit with a neonate. And even more so, we're in clinical literature, even outside of pregnancy, we're trusting um, our home measurements more than office measurements. So this committee opinion also suggests that if an in-person visit isn't available, we should really be trying to utilize blood pressure monitoring for the patient at home, maybe including home visits, phone support, text messages, remote blood pressure monitoring, where the blood pressure readings are uploading into the EMR for easy clinician access. And then finally, app-based support, anywhere where we can insert technology to help alleviate the burden for patients. So that's a little bit about the background within the actual risks within the postpartum period, but let's now touch on the actual disparities within postpartum healthcare. And when I talk about disparities, I'm specifically talking about this definition, which is a difference between population groups in the way they access, experience, and receive care. So I think when we're addressing disparities, we can't just think about um, the services we're providing or maybe things that we do for every patient, but we're actually assessing, can the patient access the care we're providing? And how is the patient's actual experience with the healthcare? Because that's going to impact their adherence to care, and it's going to eventually affect their actual outcomes from the care. So as we touched on, the risk factors for maternal cardiovascular mortality are considered or historically considered to be Black race, age greater than 40 years, prior history of hypertensive disorders and obesity. I think more question has been posed recently, specifically about Black race on its own being a risk factor. And the reason behind this is because we are discovering that healthcare disparities are extremely prevalent among the population of Black women. So the question becomes, is it Black race as an independent risk factor for mortality, or is it actually the healthcare disparities within the Black population that are driving mortality? Because if we actually look at the data for Black women versus women of other races, we know that Black women are more likely to have hypertensive disorders of pregnancy, more likely to have cardiovascular complications, actually 3 to 4 times more likely to die to pregnancy-related causes, which is extremely significant. If you look at this graph, it shows the years 2018 to 2021. Um, the y-axis shows deaths per 100,000 live births, and it splits it up by total, and then it splits it up into non-Hispanic Black, non-Hispanic White, and Hispanic race. You can see how much larger, just visually, the non-Hispanic population is. You could see the increase over years for the entire population, which highlights what we said in the beginning about the mortality risk actually increasing in the US regardless of race. But you could see here the incredible disparity that non-Hispanic Black women have in terms of maternal mortality outcomes. And for a long time, I think this was overlooked, both um, postpartum care, but also Black maternal morbidity and mortality specifically, and the disparity in care. I think something unfortunately that brought it to the public's attention was when Tori Bowie, who was a Olympic athlete, Olympic runner who had won a gold medal in the 2016 Olympics, died of childbirth complications in her 30s at home, not receiving care, and unfortunately passed away alone due to eclampsia. Um, and I think this really brought to light that these are not just very sick patients or very unhealthy people, unhealthy Black women who are having maternal mortality. This is all Black women. This includes a very healthy young Black woman who was literally at the prime of her life and had just won an Olympic gold medal years prior. Um, so, highlighting that this is across the entire population and disparities have to be addressed, not just overlooked. So question 3 is which of the following impact disparities within maternal morbidity and mortality? And for this, it's a select all that apply. Okay, great. A lot of you got the select all that apply. So I see that it's high percentages and implicit biases systemic discrimination, slightly less in incidence of chronic diseases, and another high percentage for social determinants of health. So for this question, I would say that all four are impacting disparities: implicit biases, systemic discrimination, incidence of chronic diseases, and social determinants of health. And because when we look at all of the different factors that relate to Black maternal morbidity and mortality, we could see that likely each of these is playing a role. So in terms of implicit biases, this could affect not only their care at the inpatient level, but could affect also their actual diagnosis of hypertension, whether it be chronic hypertension prior to pregnancy or in their outpatient pre-pregnancy OB visits, delayed diagnosis, which is leading to those complications in care. We could also talk about systemic and structural healthcare discrimination. So within the actual healthcare system, barriers that prevent patients from accessing the same quality of care. Increased incidence of chronic diseases. So we know that Black women prior to pregnancy are more likely to have certain chronic diseases, such as chronic hypertension, which therefore increases the risk, as we mentioned, of having a hypertensive disorder pregnancy. Limited healthcare access and coverage, specifically for certain populations, including the Black community. And then finally, other social determinants of health, such as lack of adequate housing, education, economic stability, and transportation. So we'll touch on each of these in more detail. In terms of implicit bias, specifically in obstetrical care, we know that stressful working conditions have been linked with an increased risk for implicit bias. And stressful working conditions, meaning healthcare practices where there are high stress environments. So this could be your emergency department's critical care, but another high stress environment is obstetrical care. And within high stress environments, we know that quicker decisions are made, quick judgment decisions, things are, perhaps overlooked in the urgency of care. And this we know is linked with a higher risk for implicit biases coming through in those quick high stress situations. The Society for Maternal Fetal Medicine also released a survey to actually the recipients of their journal, so maternal fetal health clinicians. And 84% of clinicians agreed that disparities affected their practice, but only 29% believe that personal biases affected patient care. Um, so I think this really just highlights the disparity between clinicians knowing that we have these healthcare disparities within care, but not acknowledging that perhaps their own implicit biases are affecting care as well. We also know that 30% of Black and Hispanic women who deliver in hospitals report provider mistreatment versus only 21% of white women. And then finally, a 2012 study showed that cesarean sections were more common among Black and Latino women than white women, even when adjusted for medical necessity. So a lot of times hypertensive disorders of pregnancy do necessitate cesarean section since delivery helps alleviate some of those complications. But this study essentially said that regardless of the hypertensive disorder of pregnancy or other reasons for C-section, Black and Latino women are having more C-sections, which C-sections are in general just a higher risk for complications for any woman during pregnancy and during delivery. In terms of structural and social determinants of health disparities, this is um, I would say a more complicated view of how historical policies and the history of the treatment of the Black community in America has actually continued to affect social determinants of health and therefore continued to affect maternal and infant mortality. There's a really good 2023 article that I found in preparation for these slides and this presentation which had this great quote, which I wanted to share with you, which is that intergenerational transmission of the stress that stems from cumulative exposure to interpersonal racism have been associated with unfavorable pregnancy and childbirth outcomes, which resultantly have significant and multifaceted implications for long-standing maternal and child health outcomes. So this article essentially suggested that the chronic stress that is put on the Black community and Black mothers intergenerationally, so intergenerational chronic stress and allosteric load can actually impact the health outcomes continually of patients and Black women in the Black community. And it also traces back the history of our nation and the policies that have been enacted and how they're still affecting social determinants of health today. So when we think about redlining, such as like our practices in New York City, we still see the effects of redlining today where Black families weren't allowed to relocate to other areas where there were, they weren't allowed to rent or purchase property in areas where there was greater economic opportunity, greater access to um, food food stability and healthcare access as well. And we still see that if we look at a demographic breakdown of New York City today, these areas that were reserved for Black population still have a majority Black population and still see the same disparities that they saw 50 years ago with limited healthcare access, limited food stability, limited education, transportation, and housing resources. So the effects of this discrimination is still seen today and is actively impacting patient care and resultantly the increased maternal mortality and morbidity. In terms of specifically healthcare access, we could think about financial barriers. So there are significant insurance limitations. Women of childbearing age may not have insurance, and many women are unemployed, especially um, people of color and Black women. And thankfully, in the United States, federal law mandates that Medicaid provide postpartum Medicaid coverage for any patient in the postpartum period for 60 days after delivery, as long as they fall within a certain threshold of the federal poverty level. So federally, that's 138%. There is a Medicaid coverage gap here. So obviously, after those 60 days, then the patient would still have to seek insurance and seek coverage. And also, it's not covering those patients who may be higher than that federal poverty threshold. So these are still high-risk patients that we need to um, assess for assistance with medications, with medical insurance, and affording care. There's also limited healthcare resources, so I'm sure, as you all know, there's provider shortages right now in terms of provider care, primary care providers, but also maternal fetal health providers and obstetricians. So this offers an opportunity for mid-level practitioners and for clinical pharmacists to take a more active role in postpartum care and other outpatient or inpatient care to try to alleviate some of this workload burden and assist with medication management. We also know that in many maternal fetal health facilities, there's clinician burnout and understaffed, or they may be overcrowded as well due to high patient volume and low volume of facilities. And then finally, physical accessibility. So transportation needs is a big thing we think within New York City for these moms and why we've really utilized telehealth to try to alleviate some of that transportation burden. But there are also many places in the US are considered maternity care deserts where women cannot access maternity care within 30 minutes of where they live. So this is a really great map from ABC News that was published about the March of Dimes, and it shows all of the areas in the US that are considered these maternity care deserts where patients can't access care within 30 minutes. And as you can imagine, I mean, we're talking about preeclampsia and these severe urgent maternal warning signs before that are truly urgent, that require urgent maternal care. And across the nation, there's these maternity care deserts where patients cannot physically access that urgent care within 30 minutes of where they live. And you can see, there's right across the map. It's important to acknowledge too that there's healthcare disparities are significant in rural areas, not just urban areas. So many rural areas are these maternity care deserts. And importantly, this map is from 2023. So there's a potential that this red area has grown over the past few years. And then we'll touch on addressing and closing these healthcare gaps. So we talked about the gaps, and now we'll talk about how we as pharmacists and pharmacy technicians can actually address and alleviate these. Thankfully, we do have national initiatives that assist with awareness and assist with helping out these disadvantaged populations. So the CDC has the Erase MM program, which is enhancing reviews and surveillance to eliminate maternal mortality. And what this does is it funds maternal mortality review committees, which are essentially committees in each state that review maternal mortality across the state and try to identify how this maternal mortality is caused, what the causative factors were, and then trying to improve care across the state to try to prevent these from happening in the future. They also have the Hear Her campaign within the CDC, which is a public-facing social media advertising and awareness campaign that raises awareness for urgent maternal warning signs for providers, patients, and family members, caregivers, so that patients understand when they should seek that urgent care and the risks of postpartum hypertension. Other national initiatives, so within the United States House of Representatives, we have the Black Maternal Health Caucus with two Black congresswomen. They specifically within this caucus target legislation that can improve Black maternal mortality and morbidity, and they submitted the Momnibus Act, which I thought was a clever name, but it's 13 individual bills that invest in social determinants of health in Black communities, expand telehealth and digital tools for improved accessibility for care. They fund other community-based organizations to spread awareness and assist in the community. And then they are aiming to improve quality measures and data collection processes within healthcare systems so that we could better understand um, the social determinants of health and other factors that are increasing mortality and morbidity. Unfortunately, this was, introduced in Congress in 2021, and it's currently still in progress, so this act has not been passed. We could hope that this caucus continues to work on behalf of the community to help alleviate these healthcare disparities and that at least some of these bills are passed in the future. Other national and state initiatives include the American Heart Association, which did include a statement about the importance of addressing maternal postpartum hypertension care, and importantly, the disparities within care and how we can address these as healthcare providers. And then, really good news is that in New York State, in 2023, they passed a law extending the period for Medicaid coverage for mothers in the postpartum period. So, as I mentioned before, on a federal level, um, Medicaid has to be provided to patients 60 days after delivery. In New York, we passed a law where this Medicaid coverage is expanded for a full year postpartum. So significantly cutting down on that coverage gap. And in addition to it being a year, they raised the threshold for eligibility. So now patients are eligible within New York State if they're within 223% of the Medicaid or the federal poverty level. So really great news within New York State that will hopefully increase our level of care throughout the period, increase healthcare accessibility, and decrease maternal morbidity and mortality. Other specific initiatives that have been within our own healthcare system include the Maternal Health Equity Symposium, which was held in February. This was a symposium for all healthcare providers within the system to discuss our current quality improvement initiatives for maternal health. And we had a number of speakers, one of which was Charles Johnson, who is the founder of For Cura for Moms. And his wife, who is Black, unfortunately passed away due to preeclampsia and childbirth complications that could have been potentially preventable. And so he founded this community-based organization to spread awareness of the disparities within the Black community, spread awareness of the risks of hypertensive disorders of pregnancy, and also fund other community-based organizations to do the same. Other initiatives include the Black Maternal Health Week, which was founded recently by the Black Mamas Matter um, community. And this is another community-based organization that is aiming to spread awareness of Black maternal mortality and morbidity. And then finally, from a healthcare perspective, we have the Association of Black Cardiologists. And one of their goals, similarly, from a healthcare perspective, is to also raise the awareness of Black morbidity and mortality during the postpartum and antepartum period. So question 4, then the final question is, which of the following services can pharmacists or pharmacy technicians provide to help address postpartum healthcare disparities? And this is single choice. So when you think of this, I would think of what do you think is probably the best avenue right now for pharmacists and pharmacy technicians to have the greatest amount of impact within this care? So the majority said incorporate remote patient monitoring services. Next was eliminate intergenerational structural discrimination. Then lower was provide early diagnosis of chronic disease and establish insurance coverage on behalf of patients. I would agree that incorporating remote patient monitoring services, I think, is the most realistic way for pharmacists and pharmacy technicians right now to directly impact patient care. I think eliminating intergenerational structural discrimination is the eventual goal of us all as healthcare providers, but is something that I think is not possible with pharmacists or pharmacy technicians alone. So this is what requires interdisciplinary and structural change to make happen. In terms of providing early diagnosis of chronic diseases, I think it's important that pharmacists are accessible for patients and available because we can help triage patients to make sure that they're seeing their primary care providers. We'd screen for patients for blood pressure management, but we need to ensure that patients are not just seeing pharmacists, but also connected with a primary care team, connected with their obstetrician providers to make sure that they're uh, appropriately getting diagnosed. And in terms of establishing insurance coverage on behalf of patients, of course, this is important for all of our patients, but um, again, it's important to have a team-based approach. We as pharmacists and pharmacy technicians cannot do everything alone. If you have community health workers or social workers on your team, they're probably the most equipped to help with insurance coverage and help with these processes. And we should envelop them in our system and our team-based components and make sure that each of us is doing our part to ensure adequate care and accessibility. In terms of more pharmacy-specific opportunities, I think we have a lot of room to identify social determinants of health and risks of maternal morbidity and mortality before they occur. So if we remember that our risk factors are Black race, prior history of cardiovascular disease, obesity, age greater than 40, we could identify patients who may be a higher risk during pregnancy and identify them prior to pregnancy. So if a patient's planning to become pregnant, making sure that they're connected with care if they have some of these risk factors, or maybe a patient who isn't connected with care at all prior to their pregnancy. We have to keep in mind social determinants of health, so education, economic stability, healthcare access, and community and environment that we know can affect their care, their adherence to care, and their directly affect their health outcomes. So anywhere that we can, we have to address these social determinants of health and make sure they're well connected with the team, such as social workers, to make sure that these social determinants of health are assessed and not just at office visits outside at home too. We as pharmacists are considered very accessible, so we can improve healthcare accessibility. Telehealth has exploded within the past few decades, especially remote patient monitoring. So Nowadays, a lot of remote patient monitoring systems are integrated within the electronic medical records, so within EMRs. Similar to how we have CGMs in practice and utilize glucose monitoring reports that are reported to the clinic, we could similarly do the same for blood pressure monitoring as long as we have the connections with the services that provide this. We want to utilize technology when possible. So utilizing apps, utilizing Epic My Connect for tech-savvy patients, utilizing phone calls for patients who maybe aren't as tech-savvy and require phone instead of telehealth visits. And then finally, expanding the pharmacist's scope of practice to enhance interprofessional collaboration. So through an expanded scope of practice, such as a collaborative drug therapy management agreement, a CDTM agreement, which we have at our clinic, it allows us to independently see these patients, independently manage their medications in coordination with the team, which improves the timeliness of care without needing to extensively coordinate for every independent visit with the provider. And then we want to optimize chronic disease management as well. So, as I mentioned, screening for patients is important, but also managing the patients prior to pregnancy, managing their chronic conditions prior to pregnancy and during pregnancy is important because a chronic hypertension patient who isn't managed well on antihypertensives that um, during pregnancy is at a higher risk for superimposed preeclampsia and therefore at a higher risk for maternal mortality and morbidity. And then finally, we need to educate patients and family, and this can come from a technician or a pharmacist standpoint. So we have a lot of touch bases with patients in the inpatient and outpatient environment. We should actively be involved in medication management for pregnant patients, understanding what medications can be used in pregnancy, and in terms of postpartum hypertension, how to manage antihypertensives for patients. We can also counsel patients on blood pressure monitoring technique, so making sure that patients understand how to monitor their own blood pressure at home, because really home blood pressure monitoring is critical for outpatient management for these patients. And then finally, making sure that patients understand the risks of postpartum hypertension, understand the risks of hypertensive disorders of pregnancy, and understand the urgent maternal warning signs where they really should seek urgent care or contact a provider for urgent follow-up. And for your reference, those things like typically we'll ask at a clinic are things such as shortness of breath, severe persistent headache, vision changes, shortness of breath, chest pain, all of which can indicate end organ damage from hypertensive disorders of pregnancy. And thankfully, we've had prior literature that has assessed the effectiveness of pharmacists being integrated into outpatient postpartum care settings. So at Yale, they had a study that aimed to assess how clinical pharmacist integration in the outpatient space through telehealth can hopefully improve compliance to those ACOG guidelines of managing patients within that 7 to 10 day period and um, successfully capturing and preventing those cardiovascular complications. So when they looked at the pharmacist integrated model versus the PCP or OB only model, they saw that 94% of patients saw a healthcare provider within 10 days of discharge in the pharmacist arm versus only 65% without. They saw a shorter number of days until follow-up, so a mean of 4 days in the pharmacist group versus 7 days in the usual care group. And their conclusion was that a team-based RPM program is feasible and also helps connect patients to care quicker, which may allow for opportunities to identify and reduce maternal comorbidities and complications on a quicker basis. And we use this framework at Yale to develop our clinic at New York Presbyterian, so it's similarly structured at our Weill Cornell campus. It's funded by our Center for Health Justice at New York Presbyterian, which is a center within the enterprise that aims to understand and address healthcare disparities. It invests in research, education, and programming and works on building a network of initiatives across the enterprise to address these disparities. And then finally, from a legislation perspective, it advocates for policy change to improve health outcomes for patients in the state and nationally. And this center provided a grants for this program specifically to address the healthcare disparities of patients in New York and patients on Medicaid and maybe experiencing these social determinants of health and assist them with early follow-up with the pharmacist to hopefully improve care and decrease the risks of maternal morbidity and mortality. So the goals, again, are to address these key factors for early follow-up within the period, similar to the Yale study, improve blood pressure management and outcomes, so hopefully prevents any morbidity and mortality, and also assist with medication titration in the postpartum period. And then finally, provide connections to follow-up after delivery. So ensuring that even after the OB timeframe, even after the postpartum timeframe when they're following with the pharmacist, they are still connected with care. They're still seeing a primary care provider for any ongoing concerns and ensuring adequate follow-up. Our interdisciplinary team at the clinic involves a number of different professions. So we have pharmacists, doctors, both primary care providers and maternal fetal health clinicians, physician assistants, nurse practitioners, registered nurses, obviously the personnel from the Center for Health Justice, IT, and the Women's Service Line all assist with a team-based multidisciplinary approach for these patients. In terms of our program workflow, the OB team is identifying these patients at the inpatient level for patients who have hypertensive disorders of pregnancy and essentially asking them if they'd like to be followed by the pharmacist for blood pressure monitoring in the postpartum period once they leave the hospital. If the patient's interested, a nurse comes to bedside while they're still inpatient, provides the patient with a blood pressure cuff that's theirs to keep, and the patient's educated on how to use the blood pressure cuff and how to upload their readings into their MyConnect, so into our Epic portal that's linked with our EMR. We have a scheduling team, and they schedule a visit with the patient with the pharmacist within 3 to 7 days after discharge. The patient is educated to independently log their readings through MyConnect, through the EMR, which uploads into the system, and we could see from our end and independently review each day. And if the blood pressure readings are high or low, we can reach out to the patient outside of the visits. But otherwise, we'll see the patient on that scheduled follow-up visit 3 to 7 days after discharge, where we'll evaluate their blood pressure management, evaluate if they have any urgent maternal warning signs, and independently manage their medication, and then independently set up follow-up visits until they're deemed ready for graduation, which is typically good blood pressure control around the 6-week mark postpartum. If they are continuing on blood pressure medications, maybe they have a new diagnosis of chronic hypertension, we ensure that they have primary care follow-up after that postpartum period is done. So we're making sure that every patient, regardless if they're doing well at the 6-week mark or maybe still need more urgent help, we're making sure that they have primary care connections after our time together. And then, of course, within that 3 to 7 day period, as we mentioned, it's a very high risk period, and even in the 6 weeks, it's a high risk period. So we're assessing those urgent warning signs during every visit to make sure that we are referring the patient to triage if they have any severe range blood pressure or any of those warning signs. This is an example of what's included within our collaborative practice management agreement. So a number of different medications that are common within pregnancy and the postpartum period and suggested titration protocols. By having the CDTM agreement in place, we're increasing medication access. We're assisting at the pharmacy level, so assisting with affordability and insurance coverage. We are at every visit educating on blood pressure management, so they're educated on how to use the blood pressure cuff inpatient, but we're also assisting and educating on this outpatient as well. And then we're also assessing for lactation safety. So many patients have lactation safety concerns, and we have a dedicated breastfeeding warm line that we're able to refer patients for and catch if they are experiencing these things. So in terms of our timeline and successes to date, We planned this clinic between October 2023 and April 2024 when we created our standard operating procedure, created new referral orders and a pharmacy template, standardized our documentation, and then finalized our postpartum hypertension CDTM agreement signed by the clinicians at the OB clinic. We launched in May of 2024, so right around a year ago. And before launching, we all attended, including the pharmacist, a trauma-informed training for advanced practice clinicians. And this educated us as pharmacists and as clinicians on the most appropriate and effective ways to communicate with the vulnerable postpartum population. We started at one campus, so we started at Weill Cornell Medicine. We're currently still there with two pharmacists and independently seeing these patients during visits. In the beginning, we averaged at around 1 to 2 new referrals each week. But as the optimization has been ongoing, we've received a steady referral volume, so around 5 to 8 patients per week. We're meeting with providers, the OB providers and medical director on a weekly basis to discuss any very high-risk patients or patients that we've triaged or patients in need of more urgent management. We've coordinated transition for a number of patients to long-term follow-up at our sister primary care site, right below the OB clinic. And then we have open dialogue with the Yale team as well to share best practices since these clinics are fairly similar. And in terms of our overall impact to date, these numbers already might be a little outdated since we're seeing patients every day, but we've had 221 patient referrals, 183 or 83% of which have engaged with at least one visit with a pharmacist. We've triaged 15 patients to the emergency department with severe range blood pressure and symptoms, 4 of which led to readmission. And we see this as a really good number because this means we're catching patients who might have otherwise not gone to the emergency department or be admitted, who were in need of it due to their urgent maternal warning signs or high blood pressure. We've adjusted antihypertensives for 73 patients, or around 40%. We've referred 9 patients to the breastfeeding warm line I mentioned, connected 45 patients to a primary care provider at NYP, mostly for patients who didn't have any primary care provider and might have otherwise not had follow-up. At every visit, we educate patients on their diagnosis, those severe maternal warning signs, blood pressure goals, and device technique. And then to date, we've graduated 154 patients from the program based on appropriate blood pressure control with or without medications. The measures we're collecting for data purposes for the future, for process measures, we're looking at making sure that our staff has successfully completed training, education, and onboarding, tracking the number of patients who were referred for pharmacy visits and the number of those who were actually seen by the pharmacist, the time to engagement in care. So remember that time is key. We're trying to follow the ACOG guidance and make sure that we're seeing patients as soon as possible outpatient for blood pressure management, and the number of visits that patients utilize. So seeing how many visits did it take for adequate blood pressure control and graduation from the program. Outcomes measures include the patient's engagement in care, the number of ED visits after their discharge postpartum, and then the number of readmissions for severe range blood pressure or other severe morbidities. And our future goal for the clinic, one is to increase clinic capacity. So in the inpatient side, they were already reaching out to any patients with diagnosed hypertensive disorders of pregnancy. But now we're starting to reach out to patients with a history of hypertensive disorders of pregnancy. Since, as I mentioned before, if patients had one of these disorders in a previous pregnancy, they're more likely to have one in this pregnancy. And sometimes these don't go diagnosed until the postpartum period. So we're following those high-risk patients as well. We're going to attempt to expand to all NYP campuses. So we've already received interest from other campuses other than our Cornell campus. So hoping to expand to those other campuses and provide care for those women, those communities as well. Analyze our program effectiveness. So obviously from our numbers, we're starting to track some of these outcomes, but after a while of this clinic being in place, we'd like to review patient satisfaction, engagement with care, and observe our readmission rates. And then finally, establish additional services. So we're starting what's called the Heart Path fourth trimester service, which includes interdisciplinary management of long-term chronic diseases. So for these patients who maybe have a newer existing diagnosis of chronic hypertension, maybe they have newly diagnosed hyperlipidemia, or they had gestational diabetes that still requires management. We are starting the service in the after postpartum period to manage their chronic disease states on a long-term basis. So that's something also in the pipeline. And as conclusions from this presentation, the big takeaways I'd like you to have are that hypertensive disorders of pregnancy, or HDP, are a leading cause of maternal morbidity and mortality that are affecting patients not only in at delivery and before delivery, but also in the postpartum period. Black women are more likely to experience higher hypertensive disorders of pregnancy and are more likely for those cardiovascular complications and are at a higher risk for maternal morbidity and mortality than their white or or Hispanic counterparts. The key barriers that likely are increasing healthcare disparities within postpartum care include those implicit biases that we discussed, as well as continued systemic discrimination or historical systemic discrimination that is still affecting social determinants of health, such as limited healthcare access. And then finally, pharmacists and pharmacy technicians can personally address these postpartum care disparities by helping to identify at-risk patients and helping to connect them with the interprofessional team, enhancing patient education, whether it be blood pressure monitoring, urgent warning signs, and medication management, optimizing chronic disease management. So for these patients who are prior to pregnancy, who may have chronic hypertension or other comorbidities, and then finally, leveraging technology. It's continuing to grow, and as pharmacists and clinical pharmacists, we need to keep on top of technology changes so that we're up to date on the most accessible options for patients to improve care. And lastly, I'd like to acknowledge Hanlon Lee and Amber Bradley for permission of adaptation for presentation content, and then our medical director, Dr. Heather Lipkind, for a review of this presentation. But thank you, and open to any questions.
Thank you very much, Dr. Thurston, for providing today's webinar and for presenting on such an interesting topic. If anyone has any questions, please put them into the question and answer box or the chat box. We'll give everyone a few moments to do that. And then in the interim, I do have one question for you. What have been some of the most common reasons that patients have not agreed to participate in your telehealth program?
Yeah, that's a great question. I would say on the inpatient side, we're not too aware since they're screened inpatient and may refuse at that time just due to a lot, I think, is due to complexity in the postpartum period. A lot of visits for their newborn, maybe they're at home, adjusting to the big lifestyle changes of having a newborn at home and recovering postpartum. Um, I don't think we've had any patients who have refused during our calls, but many patients were unable to reach, maybe with telephone lines that are no longer functioning or just inability to reach after multiple attempts. But every patient has a lot of follow-up, so we're making sure clinicians are reaching, providers are reaching out, PAs are reaching out, we're reaching out personally, and making sure that we're reaching out multiple times to try to reach these patients. Unfortunately, I think a lot comes down to accessibility, even from a telehealth standpoint.
Okay, well, thank you so much. I don't see any other questions coming into the Q&A box or the chat. If any do come up after, we will follow up with everyone who's attended via email.